without further ado, I would invite Dr. Ahmed Adlan to give us this talk about the remote monitoring and ECG diagnostic during COVID-19. Welcome.
Very much. Thank you very much, Dr. Just checking that I'm off mute yet. So thank you very much, Dr. Hind, for the introduction. And it's really a pleasure to speak about this topic today, because I think it's a very important topic, really. And it's quite a big something very valid within the COVID era as well. So I'm just going to, so the main real objectives of today's talk regarding remote monitoring and ECG diagnostics is to describe some of the problems that we face with remote monitoring within the electrophysiology department, cardiology department, but it also applies to other areas as well. I'm going to cover which patients require monitoring, what tools we have available, the traditional tools as well as novel tools. And I'm going to also talk about some suggested changes to face-to-face services during COVID. So really, we are faced with a problem when it comes to COVID. And on the one hand, we want to try to get a diagnosis for the patients that we see. We also want to try to monitor the patient's condition. We also want to be able to make management decisions, and all of these things require monitoring and diagnostics. But this is balanced against the risks that are posed to patients. So the risk of spreading COVID, implementing social distancing, and also looking after a vulnerable group of patients, what we call the shielded patients. These may be patients who are at a particular risk of COVID or having a worse outcome in COVID. For example, immunosuppressed patients. So firstly, which patients require remote monitoring or ECG diagnostics? Anyone who has any symptoms suggestive of an arrhythmia would warrant some form of diagnosis, particularly those patients where we don't have an established diagnosis. So for example, a patient with palpitations or with syncope, we'd need to get some ECG diagnostics for them. Secondly, there's a group of patients who are known to have arrhythmias, and we want to continue to monitor them throughout the COVID era. And for example, these are patients who have atrial fibrillation and you want to assess the rate control, or patients who've had a catheter ablation, for example, AF ablation. The third group really are those patients who have established structural heart disease, and these patients who may have an increased risk of sudden cardiac death. So for example, patients with hypertrophic cardiomyopathy, part of the screening process to assess whether or not patients require an implantable cardioverter defibrillator, or if they're high risk of sudden death, involves ECG monitoring to look for non-sustained VT. That's just one example. But the other group of patients are those who have cardiac devices. They've got permanent pacemakers or defibrillators. We need to continue to follow these patients up to have a look at their arrhythmia burden, make sure the devices are working appropriately. And then there are another group of patients who may benefit from monitoring and ECG diagnostics. So for example, patients who've had a stroke which is unexplained, we may need to do some monitoring to look for evidence of atrial fibrillation. So what tools do we have? Well, I've split them in terms of traditional and novel. And so these are the traditional tools. And by far for me as an electrophysiology fellow, the 12-lead ECG is one of the most important investigations for my patients. But you can see on the cartoon on the right that the main problem with this is physical contact and the proximity that patients you have to actually be very close to a patient to put on the ECG electrodes to perform the ECG. The other types of monitoring we have are the Holter monitoring, which involves patients placing leads on the chest and taking the device home with them. in the community. They can wear the tapes for 24 hours, 48 hours, 5 days or 7 days, and that provides continuous ECG monitoring. Most of this type of monitoring involves usually 1 lead or 3 leads. There are 12 lead ECGs available, 12 lead ECG Holter monitors available, but they are quite expensive and they're not widely used, and they may not be available in many centres. The other group of monitoring are the ECG event recorders, or the cardio memos. Now these are monitors that patients take home with them, and whenever they get a symptom, they can activate and it will record their ECG for a period of time, a few minutes usually. Also, some of them will automatically record any arrhythmias, so any bradyarrhythmias or any tachycardia arrhythmias will automatically be recorded, as well as if the patient activates it. And then, of course, we have cardiac devices which have been around for many decades, patients with pacemakers and defibrillators. Now, these patients, they usually come back to the clinic for a physical visit. If you've got a standard pacemaker, usually that's every year. If you have a cardiac resynchronization therapy or a defibrillator, it can be anywhere between 3 monthly to 6 monthly visits. That's to check on the patients, to look at the arrhythmia burden, and also to check on the device to make sure that the device is still working and that the battery is still intact. So, what are the new tools available to us? What new technology do we have? Well, actually, I've put this in new, but it's not actually that new. We have had this for several years, actually, remote home monitoring. And this, I'll talk a little bit about that in a moment, but it involves patients being at home and having a device which can then talk with and be communicated back to the doctor in the hospital. So we use this routinely for implantable loop recorders, but also we are able to use that for pacemakers, and also routinely we do use it for defibrillators as well. The second group of new technology are what we call the wearables. These are ECG monitoring recordings, which the patient can wear, and then that can communicate via a device, and that can be sent back to the doctor. So this includes the Zio patches, the Livecore Cardio, and also smartphone and watches, for example, the Apple Watch, and there's also a Huawei version of this as well. Now, this is not an extensive list. In fact, there are many, many, many more than this, but this is just a few examples that I would like to share with you today. So firstly, the remote monitoring of cardiac devices and implantable loop recorders. So on the right-hand side, you can see on the top here, number 1, this is an example from Medtronic of an implantable loop recorder. So if a patient has some alarming symptoms that may require monitoring, for example, syncope, and you want to investigate the cause of syncope, and you want to get an ECG at the time of the event, the implantable loop recorder is very useful. This is a device that you implant subcutaneously underneath the tissue in the chest, and the patient will then take this monitor, which you can see here, number 4. This is given to the patient. They take it home. They plug it in at home. That monitor can then communicate back to the hospital, and this is and the monitor communicates with the device, which is a very small device, very thin, and that's done via wireless. Then we can access the reports, which will tell us whether a patient has had an arrhythmia. And now the patients can activate the loop recorder if they have any symptoms, but also it will automatically record any events, so any bradyarrhythmias or tachycardia arrhythmias. On the top left-hand side here is an example of a trace, and I'm just going to zoom in on that. Now, we are going to have to learn, and in electrophysiology, we have had to learn new ways of looking at rhythms and arrhythmias. We are very used to using a 12-lead ECG. However, we have to learn new ways, and this is one of the ways that we can learn. This is called a dot plot. I'm not going to go into too much detail, but this is the sort of report that is generated from an implantable loop recorder. On the left-hand side here, on the y-axis, you can see that there is the interval, the RR interval. Okay, the higher the R interval, the slower the heart rate, and vice versa. And on the x-axis here, we have the time. Okay, so this is the time. Now, what we can see here, this line here is indicating the patient has some sort of stable rhythm, probably sinus rhythm. You can see that their heart rate, so the R interval is around 600 milliseconds, which is around 100 beats per minute. So you can see here, then there's a sudden change after this point here. There's a change in the dot plot. And what you can see is that it's very irregular. You see there's a lot of irregularity, and this is the R interval. So there is a change in the R interval on a beat-to-beat basis in this patient, and it's very disorganized compared to nice organized activity here. This is atrial fibrillation, and this is what atrial fibrillation looks like in a cardiac monitor, an implantable loop recorder. So the devices that we have available can also detect atrial fibrillation using various different algorithms, and they can also provide some very useful information. So they can tell us how much AF or atrial tachycardia patient has. So for example here, this is another way of looking at arrhythmia burden. So again, on the y-axis you have time. This is in a given day. So each of these lines here represent days, and you're going from left to right. So, and this is consecutive days. And what you can see is the amount of time in 24-hour period that the patient has had a device-detected AF, or we call it atrial fibrillation or atrial tachycardia. So here you can see the first line here indicates this patient has had 8 hours of atrial fibrillation, and then they had a period of time where they didn't have atrial fibrillation, and they had another 8-hour episode. And you can see that around this period here, between May 2017, November 2017, there is an increased amount of AF burden that the patient is getting, both in terms of the frequency of the episodes of atrial fibrillation, and also in terms of the duration, with episodes of almost sort of 20 hours plus. So, remote monitoring of cardiac devices. So we use this predominantly, as I mentioned, for defibrillators as a standard. What can happen is that the patient will, if they have an ICD shock or an ICD therapy, and ICD stands for implantable cardioverter defibrillator. It's implanted in patients who have a high risk of sudden cardiac death, either patients who have had a ventricular tachycardia or ventricular fibrillation in the secondary prevention manner or primary prevention manner. Now, if the patient has a therapy which either is a shock or what we call anti-tachycardia pacing, where if the patient has ventricular tachycardia, the device will detect it, and then will it be able to get the patient back into a normal rhythm by terminating the arrhythmia simply by pacing at a faster rate than the tachycardia. This is what, in terms of what we mean by therapy. So if the patient has an event where they had an ICD therapy or a shock, that will automatically alert to the clinicians. And this is done again, the patient has this device, they plug it in at home, they've got the defibrillator inside them, and it communicates via a Wi-Fi, and then that is then sent remotely to us. So we have a team, in most hospitals there's a team of doctors, a team who will have access to the patients who have these devices, and they will be able to check every day if there are any alerts. So there are many different companies that offer this. Boston Scientific is one, but also Medtronic, and there are a lot of other companies as well. And then we can look at the traces, and we can actually then action any particular management that needs to be taken. And it may involve calling the patient, making sure they're okay, and bringing them into hospital, adjusting their medications, or even arranging hospital admission. So that's one important way that we can get information from patients who are at home. We can also find out, as I mentioned, similarly with the arrhythmias, so not only ventricular arrhythmias, but also atrial fibrillation and atrial tachycardia, which I've mentioned already. And lastly, we can also get information about heart failure. And this ties into the question that we had earlier regarding how can you assess patients or examine patients without, when from a telephone consultation. Well, actually, I'm going to show you some ways that we can monitor patients with heart failure without physically seeing them. So this is an example of the type of, now I'm showing this to you just so that you get an idea of what arrhythmias look like in these devices and what the reports will look like. And this is, again, another way of looking at an arrhythmia. So this patient has got leads within the atria. So you've got one lead within the atria. So this is A. So this strip at the top demonstrates electrograms, intracardiac electrograms from that atrial lead. And this is what the atrial lead is seeing. Then we have a V, which is the ventricular lead. And this is, again, looking at intracardiac electrograms from the ventricle. And then we have this trace, which looks a bit more like a traditional surface ECG. And this, we can also use this to give us information of we can assess the morphology of the complexes, particularly the ventricular complexes. And then at the bottom, this is essentially showing you what does the device think it's seeing. So this is at the bottom is the device's interpretation of the above data. And sometimes it gets it right. Most of the time it gets it right. Sometimes it does get it wrong. The information, so what it will tell you, so for example here, there's different codes. This is atrial sensing, AS. You can see here it's saying it's sensing atrial sensing. So actually it's doing pretty well here, atrial sensing. And then it's saying that this is a PAC, premotor atrial complex. Then it's describing the next 3 beats as AF, or atrial fibrillation. Then it's saying atrial sensing, etc., etc., etc. And then you can also see at the bottom here, the same information, but this is from the ventricle. So this is what the red line, how the device is interpreting these signals. And again, it's saying ventricular sensed, and then it's labeling this as VT, 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 VT. If you look, you can also see that we can have information of the R interval. So we can actually see how much the R interval varies from each beat to beat. So what's the diagnosis here? Well, this is actually a case, this is a patient who has had VT. Okay, so this is what VT looks like. I've showed you what atrial fibrillation looks like on a dot plot. This is what VT looks like on an electrogram. And what you can see here is that the easy way to assess this is to look at the number of ventricular beats and compare them to the number of atrial beats. So in a normal rhythm, sinus rhythm, they should be the same. Sinus and then a ventricular beat. So an atrial beat, ventricular, atrial. Here we can clearly see there are more ventricular beats than there are atrial beats. And that really is diagnostic of ventricular tachycardia. So this is what ventricular tachycardia looks like. And in fact, this is a short episode, non-sustained VT, which then terminates. And this here on the right-hand side, you can see an atrial, ventricular, atrial, ventricular, atrial, ventricular. This is sinus rhythm. This is what sinus rhythm looks like. And you can look at the morphology of the QRS, and you can see that there is a difference in the morphology, although it's a bit more subtle in this particular case. You can see there's broadening of the QRS there, and this is sort of a narrow QRS. Now, in terms of heart failure monitoring, so Medtronic have a system called Optivol, which allows us to monitor the fluid status of patients, and this is in patients who have cardiac resynchronization therapy. CRT devices. Now, for those who are not experts within cardiology, this is we call this a device therapy, and it's one of the therapies that we use in patients who have heart failure with reduced ejection fraction. So they have an echocardiogram demonstrating a reduced ejection fraction, the left ventricular ejection fraction of 40% or less. The patients, before initiating device therapy of CRT, they need to be on optimal medical therapy, ACE inhibitors and beta blockers, also spironolactone. And then at that stage, if they fulfill the criteria that their ejection fraction is reduced, they still have symptoms of heart failure assessed by the New York Heart Association classification, and they have evidence of cardiac dysynchrony, which is really, from an ECG perspective, we look at the QRS duration, time it takes for the ventricles to depolarize, and the longer that is, more than 130 milliseconds, these patients should go ahead for a CRT. Now, once they've got the CRT, we can get this information from the patient who's at home. We can get lots of information. So on the left-hand side, we can get information about the fluid index, and we can also use this by assessing the impedance. So we can measure the impedance of electrical signals from the CAN, which is on this. So the box, the pulse generator. We call this the CAN. Sits underneath the skin, and whereas the leads are inside the heart. So you've got the right ventricular lead within the right ventricle, and you have the left ventricular lead, which is within the coronary sinus. So it's an epicardial lead, and you can measure the impedance between the CAN, the pulse generator, and the leads, and you can plot this and see variations and changes. So what can change? Well, if the patient develops pulmonary congestion, for example, then this may change the impedance. And using these various parameters, we can then, the device will then use algorithms to provide a fluid index, this has been validated. And on the right-hand side, again, at the top here, so for example, just going back, so if the patient starts to develop fluid congestion overload, then the device will be able to see that. So you can see here, this patient is between October and December, their optivol volume is rising and rising and rising. Now this is a warning sign to clinicians. If we see this on a trace, or on a report for a patient, this is telling us this patient is struggling, and it's very highly predictive that this patient will then have a heart failure hospitalization. The benefit of this is that this is a warning sign. So it's a warning sign, it's a warning system that's letting us know that something's not right with the patient and that they are high risk of going into to requiring a heart failure hospitalization. The benefit of it is that we can then do something about it. So we can actually contact the patient, assess them, and adjust the medications as necessary, and to have a look to see what is causing the decompensation before they end up having to go into hospital. So that's one thing I wanted to mention regarding this. On the right-hand side, there are a few other things involved with this optivol monitoring, which will be very helpful to us to try to work out why they might be decompensating. So a common reason for decompensation is a new arrhythmia, a new atrial arrhythmia, so atrial fibrillation, probably the most commonest cause for heart failure decompensation. And as you can see here on the trace on the top right-hand side, I've shown you this before, but this is just showing that this patient had no atrial fibrillation detected on the device. Up until this point, they started to get some episodes, we call them paroxysmal atrial fibrillation. And then another episode here, which is a bit more persistent. And then you can see from this point onwards, the patient has been in persistent atrial fibrillation 24 hours for many days. This will be alarming to us. This will tell us this patient has got atrial fibrillation. That we need to assess the rate control. We need to assess this patient to have a look to see what's triggered that atrial fibrillation, what can we do about it. And secondly, here is it tells us the rates. So now we know the patient has got atrial fibrillation, but obviously atrial fibrillation often causes a problem when the ventricular rates are poorly controlled. So if the heart rate, the ventricular rate is more than 100 beats per minute, then that indicates poor level of control. So you may want to optimize the beta blockers and reduce the ventricular rate. Now, it may be that the ventricular rates are not high, but the patient doesn't tolerate being in atrial fibrillation. So, for example, in patients who have conditions such as hypertrophic cardiomyopathy, they don't get the atrial kick, which is very important for cardiac output in these patients. They don't tolerate atrial fibrillation very well at all. So in those type of patients, we may need to, regardless of the rate, it's not an issue of the rate, it's the issue of the rhythm. So we may need to cardiovert that patient or bring them in for an ablation, for example. And then also the third thing that we can find out is regarding CRT. So CRT resynchronizes the heart, and the way it does that is that you have a left ventricular lead and a right ventricular lead, and whereas there was dysynchrony where one side is contracting for the other, the CRT allows resynchronization of the heart. So both the chambers on the left and the right are contracting together at the same time, and we can see evidence of that on the 12-lead ECG. We can see the QRS width, or the duration of the QRS, narrowing. So a patient has left bundle branch block before CRT. You put CRT on and they have a right bundle branch, but the QRS duration is much shorter. These are the patients who benefit. The benefit of CRT is in pacing. So the CRT, you want to be pacing more than 95% of the time to get the benefit of CRT. So in that situation, this particular device is able to tell us how much CRT the patient is getting, how much pacing are they getting within the atria here, for example, and within the ventricular. And you can see in this particular case, this patient was getting sort of the ventricular pacing was not very, was quite minimum per day here. You can see the atrial pacing was quite high, but the ventricular pacing is quite low. So if the patient is not receiving the CRT, just because they've got the device implanted doesn't necessarily mean they're receiving the therapy. So we have to assess this, and we can check this using the monitor. If the patient's not getting appropriate CRT, we have to look at the reasons why. And a few other things that we get, apart from the average ventricular rate here, you can see the average ventricular rate is around 80 beats per minute, which is very reasonable in patients with heart failure, reduced ejection fraction. But then you can see here also it keeps a record of the activity. So the devices have something called an accelerometer, which when the patient moves, does physical activity, walking, etc., exercise, this accelerometer is able to record that, a bit like when you have on your smartphone, the same sort of technology there, and it's telling us here that this patient, look at the level of activity. This is the amount of activity the patient has in hours per day. So it's about 2 hours per day. So when they're in a normal rhythm, sinus rhythm, you can see, or actually an atrial pace rhythm, you can see that they're doing pretty well. And then you can see that it's tailing off. The activity is tailing off. And again, this is a sign that this patient is not doing well. This is a sign that the patient, something's not right. And this is very predictive of getting a heart failure hospitalization. So the next thing I'm going to mention about briefly is the wearable technology. So this is just one example. This is called a Zio patch. As you can see, the benefit of this is that you can send this by post to the patient. The patient doesn't have to be physically in hospital to have this. They can get it sent to them by post, and they'll be given instructions, and they put the patch on the chest over the left hand side, over where the heart is. And these are the type of recordings that we can get. Now it's just going to zoom in on this, but it's a single lead ECG, okay? But despite it being a single lead ECG, it can be very useful for patients who have symptoms which may be intermittent. And that's why we traditionally have used it in patients who have episodes every several months. We find this can be very useful, and the patient can activate it. So on the top, on number A, you can see this patient is having an SVT. It's a narrow complex regular tachycardia, and this is SVT, and it tells you the heart rate as well. So it'll tell you what the average heart rate is, 236 beats per minute. And actually, it's pretty good in terms of the quality there. And you can actually see in B here, you can actually make out the P waves. You can actually see the atrial activity in the P waves, which is actually is very useful, very good. And sometimes monitors are not so good at seeing P waves. But you can see here, this patient has got non-sustained VT, so they have sinus rhythm, and then these broad complex tachycardia, or a few beats of broad complex run non-sustained VT, and then it terminates and they're back in sinus rhythm. Here we can also see evidence of bradyarrhythmias. So you can see that this patient there's a P wave, there's QRS, there's another P wave, and essentially there is high-grade AV block here. There's dissociation of atrial ventricle, and then here in D, you can see that this patient has got sinus node dysfunction. You can see there's no real P waves at all throughout the whole trace here. There's an escape beat here, and you can see that there's a significant pause here of about 3 seconds. So this is the type of information we can get from remote wearables. The second remote wearable that I would like to talk about is the Livecore Cardio, and I've had personal experience of using this with patients. And the patient will have this device here, and they need to download the app on their smartphone, and you press your fingers over these two areas, and it is able to record your heart activity, your heart rhythm. And again, it's a single lead recording. As you can see, the quality here of the ECG is pretty good. It can tell you a lot of information as well. I've got on the right hand side some information that you can get. I'm just going to zoom in on that. So here are some recordings here. In fact, actually, I'm just going to very briefly mention that this patient, it's not a real patient, but they've recorded they've monitored their resting heart rate. They also, if they have a blood pressure monitor at home, they can take the blood pressure and put it into the app, so you can get traces of their blood pressure. And again, if the patient carries the device with them, you can monitor their heart activity. Similarly, if the patient is able to weigh themselves at home, you can get a trend of their weight and their body mass index. And this patient has made a number of recordings here. You can see in blue are normal, or what the device thinks it's normal, and then you have some abnormal in orange. I'm just going to talk about some of these in slightly more detail here. So the one thing I would say with this type of device is that the analysis that it provides is not 100% reliable. So you definitely need a physician, in my experience, definitely need a physician to verify that that actually the recordings are real and accurate, and to assess what the rhythm is. So at the top here, this device has detected a tachycardia. It's irregular. You can't see any clear P waves. It's reported as possible atrial fibrillation. So this is the sort of information that will come to you as a doctor. You'll get this report, you'll get this ECG trace. And again, here you can see in blue, it's identified it as being normal. So normal sinus rhythm, and I think everyone can clearly see that. Again, the third case is identified it as possible atrial fibrillation. Again, we can see that there are narrow QRSs, they are irregular, no clear P waves. I mean, this would, for me, I would call this artifactual, this baseline. I would not say that is a flutter or an arrhythmia, based on the fact that the cycle length is so narrow. It's just not non-physiological, but it could be coarse AF. Could be consistent with coarse AF. And then you can see here, how does it cope with ventricular arrhythmias? Well, you can see quite clearly a sinus beat and then a premature ventricular complex. And again, for me, this is pretty good. It also will detect bradyarrhythmias, we mentioned that already. So the next type of AF screening is regarding some devices using mobile phones and watches. So for example, the Apple so the Apple Watch can be used to screen for atrial fibrillation. There's some data from this. There are two big studies. One is the Apple Heart study, which looked at using the smartphones and the smartwatch in particular to try to detect atrial fibrillation in a healthy cohort of people. So healthy individuals who have this device, having a look at them. And the second study is in using the MAFA2 Huawei study, in fact, uses the Huawei device. They're both very similar. The patient will have this device, have the smartphone, and you will get these sort of traces, as you can see in the middle here, and it will be able to tell you what the heart rate is. If they've had any arrhythmias, you'll be able to mention those arrhythmias, and you can detect them, and these reports can be sent to physicians. So this is an example of a report that's generated from the Apple Watch, and again, for me, this is pretty good trace. I think we can see that there's narrow complexes with variable rates, the R interval varying, no clear P wave activity. So I think this is for me would be clear for atrial fibrillation. So the last thing I'm going to mention is regarding those patients who are not suitable for remote monitoring, and those patients who you need to bring in to hospital, you need to bring in for physical face-to-face appointments and services. And this is based on some of the adaptations that we've had in my own centre and also in other centres. So firstly, our responsibility as physicians and clinicians is to try to minimise the healthcare contact for patients. We can do this by perhaps grouping investigations together. So if a patient needs to have an echocardiogram and a Holter monitor, let them have those at the same time. The second thing is using visual aids instead of having a face-to-face with a healthcare professional. So, for example, if a patient needs a Holter monitor, we bring the patients in and we let them go into a room, and that room, there is nobody in the room, but inside that room there is the monitor, and there are some instructions on how to use them, and that way that the patients can learn how to use those monitors without necessarily having contact face-to-face with a healthcare worker. A few other suggestions to space out the appointments. So rather than have 10-minute slots, maybe add an extra 10, 15, 20 minutes between patients to allow them to come, have their appointment, leave. So there's time in between. This is very important when it comes to cleaning of equipment, particularly things like echocardiography, for example. Try to include social distancing in the way that you set up your rooms and your clinics. Make sure that everybody knows and has the appropriate PPE. You may need to take extra precautions for vulnerable patients. So what we did in our centre is that we left those patients towards the end. So once we've actually had a trial of this of the face-to-face service, we were then, once we were happy with it, that it was working smoothly and that we could actually, make sure that patients were protected, then we opened it up for the vulnerable patients. And I think that's quite always was quite a sensible move from in our centre. The other things to think about are location. Where do patients need to come in for these investigations? Is it possible to increase the venues? For example, hospitals, multiple hospitals, or even within the community centres, or opening up centres within the general practice. So, for example, ECG is being performed locally. Rather than everyone having to come into one place, it might be better to diffuse the number of patients in different locations. We will, in our centre, we actively screen for COVID. So we call the patients up prior to the appointments, check with them, do a questionnaire, and then when they arrive, do a temperature check and make sure there aren't any changes. And then, and lastly, and perhaps most importantly, is that before we even request the investigation, we need to check, does the patient really need this? Is there an alternative way, perhaps, that doesn't involve face-to-face, perhaps some of the ways that I've mentioned already today? And also, it's very important that we choose the most appropriate test to minimize the number of visits. So we just really be a bit more careful. We try to do that anyway, but in the COVID era, it's even more important to make sure that we choose the most appropriate tests. So I'm going to stop there, and I'd like to thank you very much for the opportunity to speak today, and I'm open to any questions.
Okay, thank you very much, Dr. Ahmed. That was a fantastic talk. I think before we move to our panel, just my question, Ahmed, how are you confident by diagnosing like arrhythmia on this smart device? For example, if I got a patient, he came with query, artifact or query atrial fibrillation, as you show us one of the example of course of AF. I mean, any specific criteria or any specific device you will recommend from your experience?
Thank you. I think that's a very important question, and I think firstly, I would say I would never trust any device without looking at the traces myself, and I think that's very important that the clinicians, the physicians look at the traces. The second thing is, if you look at the traces and you see evidence of atrial fibrillation, I think this is a good question. At the moment, the diagnosis of atrial fibrillation is 30 seconds, and that's of a sustained arrhythmia, 30 seconds. But these devices only record a snapshot for sort of 5, 10, 20 seconds perhaps. That's one of the limitations that I've had. But if a patient is symptomatic, and we are able to show that they have this rhythm change during their symptoms, then I would be happy to say that patient has atrial fibrillation. If somebody is healthy and has no symptoms, and they just use this device and it picks up a tracing that looks like atrial fibrillation, I wouldn't necessarily use that as evidence that they definitely have atrial fibrillation alone, and I would personally look for more monitoring for that patient. It's mainly pre-COVID, it was mainly used as a screening tool rather than a diagnostic tool. But certainly during COVID, if they have symptoms, then I would do that. So my advice is try to follow it up with an ECG. But during COVID, it might be very difficult because of the face-to-face problems. Okay, yeah, Dr. Saeed?
Yeah, thank you very much, Dr. Adnan. Excellent talk. It's almost state of the art with all the technology you're showing us. The artificial intelligence that sits behind a lot of this, especially with Huawei and with Apple Watch, you can see the ECG tracings are almost perfect. And there's not a lot of variation that you normally see when you do an ECG on the ward. You'll see the vibrations and the patient and everything like that. So how confident are you that that technology is using artificial intelligence, and who's controlling that? Who's got the IP on this? Because it's not within the NHS where me and you work. And obviously you're working with the third parties and all these other people who obviously want to push those technologies, which is the right thing to do. But, we need to know, and with artificial intelligence coming, who is in control?
Yeah, that's a very good question. And the way that I've used it in the past is actually the patient has control of their own traces. So they sign up to whatever they want to sign up. At the moment, we don't have, in our hospital, we don't have this available as a routine service. So I think that is one of the challenges that will be faced if we do want to implement it.
Yeah.
The other thing is, I would say, I've shown you some of the best examples, just for the interest of time, but the ratio of nonsense to actual true is about 10-1. So I get a lot of traces which are just artifact, and I say I can't comment on that non-diagnostic.
A lot of noise still in the system.
Yeah.
Right. So it'll be learning. Obviously, the AI will be learning, and hopefully future iterations will improve. No doubt.
Yes, yes. Professor Junaid.
Thank you very much. That was a fantastic talk. Ahmed, I've learned more about these devices in the last 40 minutes than I thought I knew, to be honest with you. So fantastic. Well done. I think Saeed raises a very, very valid point. I think we live in a world where a lot of the device-based information sump or pool is not in our control. It's somewhere else. All these devices are centrally linked, whether we like them or not, whether we wanted to or not, even though the patient has, or individuals have control of switching this option on, we actually have no control over where that information goes other than ourselves. So theoretically, there is a centralized pool of this data that is being collected. Maybe somebody looks at it, maybe somebody doesn't look at it, maybe somebody is analyzing it, who knows. But like you rightly say, there is a lot of nonsense to valuable ratio that we need to sift through to get the examples that we can rely on to make clinical decisions and choices. I would perhaps just twist that bit a little bit differently and say what Saeed was saying, which is we don't have control over this, but clearly there is a pool of data somewhere, and we should be actively looking to have access to that data. Centrally, we should be able to say, whether as a national health service, whether as regulators, whether as for governance purposes, to understand whether that can add more clinical value to our decision making in the longer term. In the individual cases, absolutely, but collectively as a population, what the prevalence of disease is and what is being picked up, it is important that we should have data, access to that data, because it's there. It's not going to go away. The companies who own this have that data. We should use it. Thank you.
Thank you.